This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. We're delighted you're with us today. You know, last week we spoke with Dr. Stevie Puckett-Perez, who is a pediatric psychologist at Children's Health and also on the faculty at UT Southwestern. She talked about children and depression. The response was so overwhelming, we're going to bring her back and do one more segment.
And Steve, we wanted to especially thank Children's Health for helping us mobilize and get this interview out so that we could talk about some of these difficult areas that our kids and families in North Texas are facing right now. So Dr. Puckett-Perez, first of all, thank you for coming back. And second, we have a bit of a cooling off period here, summertime. But you know, one tough question that we have to grapple with, is this going to possibly have to change the way we deal with child psychology itself?
Well, sooner or later, there's got to be a bit of a bottleneck there. Something has to change so that we make kids safer. And I won't speak to, policies or anything like that, because I know this is not the place for that. But there's only so much you can do without making those changes, because otherwise what we're doing is counseling children how to live through daily trauma. And that's not how we treat trauma. We don't send kids back onto the battlefield. We don't send them back into abusive, dangerous situations. When there is danger and abuse or tragedy, we take kids away from that and we create safety. As a psychologist, it's very hard to support kids through these sorts of tragedies if we keep sending them back into them. That's not how we treat trauma. And so it just makes it very hard. But there's nothing that we can do on a psychological side of things that isn't going to require some other bigger changes at some point in time, because it is inappropriate and unethical to send children, into danger and tell them, sorry, you just got to deal with danger. Let me teach you how to cope while you feel insecure and unsafe all day in a dangerous situation. So we have to create safety in order to convince our kids that they are safe and help them heal and process. So there's very little as a psychologist or parent that we can do on our own without going out of our way as a society to create safer systems for our kids.
Amen and amen. So well said. Thank you. I've been talking to people in state and out of state over these last couple of weeks, and what I'm hearing is a lot of families are dealing with their kids saying, Mom, Dad, we don't want to go back.
That is a very hard one. Many schools here, at least in Texas, even those who had a little bit left just said, okay, we're done. And I kind of wish that other systems did that as well, because it's just those last couple of weeks have got to feel so distracted and useless, trying to be in school after something like this, at least immediately after something like this.
I know one of the tenets of psychology is we rarely will change something fundamentally until the pain is great enough. So I guess still the pain is not great enough.
I wish I could disagree with you, but it does seem to be that way. So some of the, kids that I see are older teenagers or young adults. And this generation is very kind of change-oriented and justice-minded. And, they want to know, and they come in to see me, dealing with anxiety and depression or different challenges. And they want to know, okay, how do we make it stop? What do I do? And so time after time, I hear these teenagers having more meaningful discussions about this stuff than I hear from adults sometimes. And it's really remarkable and impressive and sad all at the same time.
This is wonderful work that you're doing at such a critical time. Thank you, truly. Let's think through summer. Two scenarios. One could be a cooling off period. Another could be a building up period where we get to next fall and a child says that going back to school would be their worst nightmare.
There will be children for whom that is true, unfortunately, especially those children who are already predisposed to anxiety, whose lives have been touched by trauma or tragedy in other ways, or who have had exposure to this situation or other situations like it. Hopefully, that is not true for most children. Thankfully, this summertime, the timing of this, they were already going to start summer. And so this big pause that they have is a natural pause. It's not an artificial one that we've created. And so hopefully for most children, this distance and this, kind of spending time with family and having this reset and having this kind of secure, safe, reaffirming environment over the summer allows them a fresh start and some distance from some of this trauma and tragedy when they start school again. But as I mentioned, there will be those children who are going to be more anxious and school avoidant and dealing with some panic symptoms and big, big fears when August rolls around.
Here's one other thought. I know we all get programmed by repetition. What we see or hear or read or experience over and over sets a tone for us. So what about video games and our kids, especially this summer?
There are, and this has always been true and will always be true, that, most kids can handle video games and can handle pretend play and recognize the difference between those things. Because before it was video games, it was, running around with toy guns and sticks and things like that. Violence in play has always been true. This is not a new modern event that we are dealing with. It has always been true. Video games make that more realistic and may desensitize some kids who already had some of those predispositions or those difficulties kind of separating fiction from reality. And so for some kids, video games are a bigger risk factor than for other kids and exposure to violence. And obviously, as a child psychologist, I am encouraging families to minimize, especially after events like this, to minimize exposure to violence. However, I would say if you see violence popping up in your kids' play and in their activities after something like this, that's actually very normal processing. It's very normal for kids to act out kind of violent things and for things like shootings or pretending to die to pop up in their play. It can be very disturbing to see as a parent when that happens, but that's how kids process. Kids process through play. And so a lot of it is pretty normal. And the research on video games is actually pretty mixed in violence in video games and TV shows and things like that. For a very long time, we thought, okay, this is very problematic. It's increasing violence. It's making kids more violent. But then there's been some, newer research that suggests, actually that's not, as true as we thought it was. And so the jury is still out, but I would lean toward minimizing exposure to violence where possible.
Now that's interesting. So it gives them a sandbox, if you will, to work it out.
Yes, yeah. For some kids, for most kids, that is true. There are some kids who are more vulnerable and more predisposed to having some of those difficulties. And for them, video games and exposure to violence can be inciting and can worsen aggression and other sorts of things and kind of decrease that empathy. But that does not happen for most kids.
Dr. Stevie Puckett-Perez from Children's Health. Invaluable insights for our North Texas families right now. Another issue facing North Texas families is also the availability of infant formula for our newborns. That and what it means to be a baby-friendly hospital. It's a lot more than you might think. Next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're going to tackle another pressing headline issue that has been affecting North Texas families. Hopefully, with the news this week, it is going to improve soon, but infant formula has been very difficult to find.
That's right, Thomas. We're going to be talking about that and even more. A special designation that many of our hospitals have related to newborn moms. We're going to be talking with Dr. Theresa Patton, who is an OB-GYN at Methodist Dallas Medical Center. Welcome to our show, Dr. Patton.
Thank you so much for having me today.
I mentioned baby-friendly hospital initiatives. Can you explain to our listeners what is a designated hospital that's baby-friendly?
Well, the Baby-Friendly organization is actually a worldwide organization, and they've been designating hospitals all over the world for many, many, many years. What the system and the designation means is that a hospital has been found to have the highest level of caring for infants and their mothers and as a team, and helping those patients with their care of that infant in the first several days before they go home, and continuing that care after they get home. It's a lot about education, and it has a lot to do with feeding, both breastfeeding and formula feeding infants. And so I think a lot of times people just associate it with breastfeeding, and what it really is about empowering women in their choice of feeding their infant, and really giving that support and education to help them to get to their own goals.
You know, you mentioned in your answer there about breastfeeding. What if a patient can't breastfeed or maybe doesn't want to breastfeed?
Baby-friendly and baby-friendly designated hospitals are never about shaming anybody for their choice. What we do a lot of is educating on the benefits of breastfeeding and why we would medically supplement with formula if we had to. But we also know that there are women for a variety of circumstances who either can't or don't want to breastfeed. And so in those situations, we do education on how to safely mix formula and to help educate moms on what type of formula would be best for their baby. It is true that the great majority of the time you can be successful breastfeeding if that's what you want to do and you have the proper support, which is what Baby Friendly is all about.
Well, why wouldn't all hospitals that have labor and delivery be designated baby friendly?
Well, there's a lot of work that goes into it, and it's not inexpensive. So part of the tenets of Baby Friendly, one of the main things is that you cannot accept free formula donations. So hospitals for years have been given free formula by the formula companies because they want to get into the hospitals and get those babies, attached to a brand very early in life. And so when it comes to Baby Friendly, you have to pay fair market value for that formula. So it's expensive for the hospitals to do that. In addition, there's a lot of education that goes into educating staff and providing lactation support, and there's also fees that have to be paid to the Baby Friendly to make sure that you continue to meet those designation requirements. And so financially, it's not a smart thing for a hospital to do. However, when it comes to good patient care, the good patient care really trumps that for us, and because of that, we made the decision to go down that road and become baby-friendly designated so that we can provide that care and support to our moms.
You know, you really outlined in your answer the human side of healthcare, why a lot of times hospitals do things for their patients that people would normally think. I'm just curious, Dr. Patton, with the recent shortages in baby formulas, has there been a renewed interest in breastfeeding?
So I would say the renewed interest in breastfeeding happened much before our current time. I think the unfortunate thing that has come out of the baby formula shortage is that there's been this flip of, okay, well, then why don't women just breastfeed? Well, when your baby's 6 months old, you can't really do that. You can't turn, it's not like a switch you can flip and all of a sudden you have breast milk coming. That's why baby-friendly designations are so important, because it really takes that support and stimulation of the breast in those first few days after life to get your supply going for the rest of the time that you're going to be breastfeeding. So the shortage is still very painful, because if your baby is older than those first few days, you really can't just very easily turn on that switch and start feeding your baby breast milk. It really takes that support early on. Now, the push for breastfeeding in the United States came, I don't know, probably 10 or 12 years ago with the Surgeon General's call to action, because there are so many benefits for breast milk for infants and moms.
You know, Dr. Patton, you're a mom. Is this something you would have sought out as a young mom?
So I will say that my kiddos are 15 and 12, so I am well beyond that stage of having a newborn. But many of the changes that we were going through with Baby Friendly happened shortly after my youngest was born. And just the emphasis on family-centered care made me want to have another kid and have that baby at our facility who's baby-friendly designated so that I could have that change in care that was really focused on supporting me and my newborn. So I think if you're a parent out there seeking that family-centered, supportive environment while you're in a medical facility where you're getting the highest clinical care, I think that you really should seek out those facilities that are baby-friendly designated.
I'm curious about this whole debate of breastfeeding versus formula. How did this originate?
Okay, so in the 1970s is when formula makers started producing artificial formulas that were mass-marketed, and they did mass-market them as nutrition for your infant better than breast milk. And so often in the 70s, women who chose to breastfeed instead of formula feed were lower socioeconomic status, where it was felt that the women who chose to formula feed their infant were doing better for their infants because they had the funds available to do that. And unfortunately, that's kind of just the attitude that's been passed along for so long. So if you find those of us born in the 70s, many of us were formula fed. And so you find a lot of resistance from our parents to breastfeed our kiddos because they're still kind of stuck in that mindset of how it was promoted early on.
Wow, didn't realize that. That's very interesting.
Yeah, there's nothing living in formula. Your breast milk has lots of living components that adjust and help your child specifically to their environment.
So what are the trends today?
Oh, it is so complex right now because I would say probably 5, 7, 10 years ago, we were definitely trending toward breastfeeding. But then, like I said, baby-friendly got a bad name because everybody thought we were forcing moms to breastfeed and putting too much stress and emphasis on exclusive breastfeeding. And so there's been kind of a swing back the other direction that, you know, you're not a failure if you supplement along the way. And that is very true. We don't want to ever put that pressure on moms. But that pressure has forced moms to kind of go the other direction and put too much pressure on themselves where they're trying to pump before they have a baby so that they can get a supply in the fridge right away. And that swing, that direction has gone a little bit too far, I think. I think we all need to just kind of relax into what is natural and let our bodies do the job that they've been designed to do for years and years and years.
So new families, new moms have to make a decision, breastfeed or formula. And that's kind of an upfront early decision. Now that formula has been in short supply, how has that affected those family discussions?
So what I will tell you is that patients that I'm seeing now who are pregnant are much more interested in breastfeeding education because they are fearful of that. And that's unfortunate. It's unfortunate anytime we have a situation where our moms have, you know, yet another thing to worry about after baby's here. You know, as pro-breastfeeding as I am not celebrating this moment in time.
So what happens if a mom or a family has committed to formula feeding and they're 2 months down the road and they can't get any? What happens?
So the advice that they're being given now is to talk to their pediatrician because sometimes formula companies will give stores to pediatricians' offices or the pediatrician's office can have some knowledge about where they can go from a WIC standpoint to get stores. You know, the really unfortunate thing that we see is that patients will turn to the internet and sometimes they will order products that are not safe. And so that's concerning. But also they'll turn to breast milk that they can purchase online, and that's also been found to not be safe because people who are selling that online sell it by volume. And so we've seen they've done tests on many of those products, and that's actually watered down breast milk. And so your baby's not getting the nutrition that they need.
Dr. Theresa Patton, OB-GYN at Methodist Dallas Medical Center. Thank you for being with us. Both of these very important conversations you've just heard are on our podcast, The Human Side of Healthcare, also on our YouTube channel under the same name. When we come back, we're going to tackle another one on the human side of healthcare. This is a silent disease that needs early detection to save lives. Ladies especially, stay right there with us.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. You know, there are some medical diagnoses you just don't want to hear. One of those, ovarian cancer. There are going to be 20,000 new cases of ovarian cancer projected this year in the United States. Many of those here in North Texas. But there is hope. There is new treatment, new technology, and new ways that we can overcome this serious cancer. We're delighted that we're going to have with us Dr. Brandon Roane, who's a gynecologic oncologist at Methodist Dallas and Methodist Charlton Medical Center. Dr. Roane, welcome to the show.
Thanks for having me, Steve, and I really appreciate the opportunity to talk with you and talk about a topic that's very important for the women of this area and the women of this country.
You're absolutely right. You know, ovarian cancer has been titled a silent disease. Can you explain why is it called that?
Sure. There's two components to that descriptor. The first would be that ovarian cancer presents with very vague symptoms, nausea, bloatedness, some swelling, and feeling tired. The average age of ovarian cancer is about 60, 61. And so most people of that age have those symptoms. And so when they present to their primary care doctor, those symptoms are attributed to different things. And so they get passed down the line with additional workup and miss evaluating the GYN organs. And the second part of that is, unlike our other gynecologic cancers, there's no effective screening for ovarian cancer. So we have the Pap smear, which is a wonderful innovation for detecting cervical cancer prior to the onset of cancer. That kind of test does not exist for ovarian cancer, unfortunately. And so there's no way to proactively evaluate women for this diagnosis, unfortunately.
You know, you mentioned in your answer that the average age is around 60. I actually had a friend whose mother had ovarian cancer. And as you said, she went to the physician routinely, but she developed ovarian cancer at age 35. Is that unusual?
There are more rare types of ovarian cancer. So the most common type, which represents about 85% of all ovarian cancer cases, does present at an older age. But there are other types of ovarian cancer that do affect women in their 30s and 40s and even some adolescents. And so, you know, you got to keep those types on a differential when you are working up women with gynecologic abnormalities, even at a young age. So, you know, just because you're young doesn't mean you can rule out or dismiss the diagnosis of ovarian cancer.
As you mentioned, even adolescents, younger women, and of course, the more common age of 60, are there things, even though there may not be a test, are there things women can look for or symptoms that may at least point them to go see their physician?
You know, the most common things that women present with are abdominal swelling or bloatedness. Mostly that's because with ovarian cancer, it presents with fluid in the belly. And so women just chalk it up as, you know, weight gain or changes in body with age. And you know, if you start to notice swelling in the abdomen or pelvis and changes in bowel function or even changes in urination, you know, those things do warrant evaluation from your physician for a variety of reasons, among which would be workup for abnormalities of the gynecologic tract. A sonogram is a very minimally invasive, cost-effective test that, you know, a primary care physician or a gynecologist can order that can easily evaluate the GYN organs and at least see if those are normal and, you know, rule out or encourage an additional workup for the things that are found on that imaging.
So you touched a little bit on age. Can lifestyle or diet impact ovarian cancer?
There are no particular environmental factors that would put women at risk of ovarian cancer. So the way we think of smoking correlates with lung cancer or cervical cancer. There are factors that could reduce your risk of ovarian cancer. So we know for women who have things to decrease ovulation. So if you're on birth control pills or if you are pregnant, things that reduce the number of times you undergo ovulation or have a cycle, reduce the turnover within the ovary. However, those aren't really reasonable preventative strategies to employ to say to women, take birth control so you reduce your risk of ovarian cancer, or undergo salpingectomy or removal of the fallopian tube to reduce your risk of ovarian cancer, or get pregnant. Those aren't reasonable strategies. And so the main factor for ovarian cancer is genetic and family history. Those are the things that we really look at for risk factors for ovarian cancer.
You know, many women unfortunately have irregular menstruation cycles. Does that in any way impact ovarian cancer?
Not necessarily ovarian cancer, but it does, from my standpoint, would warrant workup that could find incidental findings that would point to ovarian cancer. Most commonly with irregular menses or irregular cycles, my concern as a GYN oncologist would be endometrial cancer, which is the most common cancer that I treat. So being aware of your menses is very important, and the regularity of it, so that, whatever the etiology of the abnormal bleeding is, you present and get the appropriate evaluation.
We're listening to a potentially life-saving interview with Dr. Brandon Roane from Methodist Dallas Medical Center. You can find this and our other 2 interviews on our podcast and our YouTube channel, The Human Side of Healthcare. Steve?
You mentioned family history impacts this. What is your recommendation for women as far as seeing a gynecologist, and just what is your overall good health care for women?
I think up through adolescence, a pediatric evaluation is important for a variety of reasons for young women growing up and the issues going along with that. But once you hit the age of 18, having someone that can do a regular annual pelvic exam is essential. And so that could be a family practice doctor. Some internal medicine physicians do that as well, nurse practitioners, physician assistants. Someone who's able to perform an effective pelvic exam is important. And then once you reach the age of 21 is when the recommendation is to start to undergo routine Pap smears. And so as a part of your annual exam every 3 to 5 years, obtaining a Pap smear would be recommended. And then with regards to family history, just knowing your family history is really important, and knowing, what specific diagnoses run in your family. And don't be afraid to ask questions. I think a lot of women hear the words such as fibroids or tumors, which could be benign, and think that their mom or siblings were diagnosed with a cancer. But asking for that clarification to know was it truly cancer and what organs were affected is really important. And I think that's one of the things that I find in my evaluations with my patients, that there's some disconnect sometimes between what the patient understands to be the diagnosis and what their family actually was treated for. And so it's our job as physicians to really be clear and really articulate what we're treating and why we're treating it.
Is there any relationship for women between other forms of cancer and ovarian cancer? For example, if a woman has breast cancer, is she more at risk for ovarian cancer?
Yeah, so the breast cancer connection is definitely very strong. The same genes that we test for that put a woman at risk for ovarian cancer have an even stronger risk for breast cancer. And that's sometimes how we find these women is, the breast cancer is the highest female-related cancer in America. And so a lot of these women are getting evaluations and workup for their breast cancer and then find that they are at risk of ovary cancer. And so that's a lot of the ways that I get referrals from patients from that standpoint. The other thing is with breast cancer, the treatment and management of breast cancer can cause risk of the appearance of endometrial cancer or uterine cancer. So hormonal therapies used to treat breast cancer can stimulate overgrowth within the uterus. And so a lot of times I will get referrals for patients to undergo a hysterectomy so that they can have effective therapy to treat their breast cancer. So while the disease itself doesn't put them at increased risk of uterine cancer, the treatment could. And so that's another connection.
I want to be positive also on this. So you mentioned women should come in routinely and do the things you've previously discussed. We know there's no specific test for ovarian cancer, but let's assume you have a patient who comes in, does everything you ask, routinely has tests, but you do detect ovarian cancer. What is their outlook at that point?
Depends on the stage, which I think is applicable to all cancers. One of the bigger storylines recently with regards to ovarian cancer is Chris Everett, which, overall renowned tennis player who was diagnosed with a stage 1 ovarian cancer. She's going through her treatment, had surgeries, undergoing chemotherapy. But most women, the average stage of ovarian cancer diagnosis is stage 3, unfortunately. And so that's what we're working with research to get that, move more people into the stage 1 category at time of diagnosis. If someone comes in, with stage 3, the chance of remission is about 75%, but the chance of recurrence is, over 50% for those women as well. And so, but we are making significant strides in the field of gynecologic oncology. I will say that this is an exciting time for treatment for our patients. The innovations with surgery and treatment are coming in bunches right now. And so from the field, the 25 years ago, we established the care of chemotherapy, and that was the standard of care with some marginal changes. But over the last decade, new drugs, new molecular therapy, new surgical approaches, new understanding of the treatment strategies have come out and have benefited women greatly. And so while I'm able to quote you numbers based on the textbook as of right now, I think that mark is moving. I think in 20, 25 years in the future, we're going to see an improvement in the outcome of women with ovarian cancer.
This is Dr. Brandon Roane. He's a gynecologic oncologist at Methodist Dallas Medical Center. As with so many of these things in our body, the sooner we detect them, the absolute better. And when we come back, we're going to ask Dr. Roane if genetic testing is in order here with ovarian cancer. Also, check out our podcast and our YouTube channel, The Human Side of Healthcare.
Covering the healthcare topics that matter most to North Texas. This is The Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. Jumping right back into our life-saving interview with Dr. Brandon Roane, gynecologic oncologist at Methodist Dallas Medical Center. We're talking ovarian cancer. Steve?
If you have a family history of ovarian cancer, should you get genetic testing done immediately?
It definitely depends on the degree of separation from your family. And so what we find now actually is that anyone with ovarian cancer is indicated for genetic testing. And so if you have a family member who was diagnosed with ovarian cancer, that person should undergo genetic testing as part of their routine management of their ovarian cancer. If that person is positive for one of the common mutations that put them at risk for ovarian cancer, then that definitely should disseminate down the family tree to other women to undergo similar testing. If that person is negative and does not carry a mutation, then that does kind of lessen the concern, especially if you have direct line of relationships like your mom or a sister. You would want to closely follow and see if they are being tested and have been tested and what their mutations were, if any. Unfortunately, some women have passed with ovarian cancer without being tested. So if that's the case, the family history would, necessitate that you would get tested to make sure that you aren't carrying a mutation that could affect you.
We've focused a lot today talking about ovarian cancer, but there are many women that are listening to this broadcast. Do you have any comments or thoughts on other gynecological cancers that you'd like to share with them?
So as I mentioned previously, the most common cancer I treat is endometrial cancer. That disease in particular presents with postmenopausal bleeding. And so if you have undergone menopause and are no longer having menstrual cycles, if you experience any vaginal bleeding, that requires a workup. It's not an emergency where you need to go to the emergency room, but you need to seek out your primary care doctor or gynecologist immediately to get an appointment set up to get evaluated. Most endometrial cancers are diagnosed in early stage because of this. So prompt evaluation really does lead to overall cure rate of 95%, most often with surgery alone. And so that'd be my recommendation for endometrial cancer. From a cervical cancer standpoint, which is the third highest malignancy that I manage, one of the things I think people don't realize is the link between cervical cancer and smoking. We have the black box warning on cigarettes that came from cases with lung cancer, and that's the most common association, which it makes sense that you were inhaling carcinogen and the lungs are affected, but there isn't even just a strong correlation between smoking and cervical cancer as there is with lung cancer. And so that's a modifiable risk factor that to stop smoking, decreasing your risk of cervical cancer. And so just added as additional motivation to your overall health to quit smoking.
Does obesity in any way impact cancers that you deal with in your practice?
Yes, obesity specifically links to endometrial cancer. We know that the increased tissue from obesity leads to increased levels of estrogen, and it's the increased level of estrogen after menopause that leads to the development of endometrial cancer. And so that's, as we see the trends of obesity increase throughout America, that's correlating with the increase of endometrial cancer as well. And I think this overall, in general, this is not specific or unique to my field, but obesity makes it difficult or provides limitations to treatment sometimes. And so surgical management or medical management can be limited due to health related issues due to obesity. And so overall management or reducing risk factors for obesity, diet, lifestyle modifications, those kind of things, if you are diagnosed with a cancer, does make it easier to give you all the options and treat with what's best based on the disease.
You know, the past 2 years we've dealt with COVID, and I know COVID is not directly related to ovarian cancer in any way, but in your practice in the last 2 years, has COVID impacted people not coming to see you, postponing appointments, or do you have any thoughts on COVID and how it's impacted female health?
Yeah, I think that's an excellent point that I think a lot of us are seeing, and from an oncologic standpoint has really impacted our practice, that COVID has made people reluctant to come in for their routine appointments, undergo screening, particularly for my field, be reduced number of pap smears or pelvic exams, leading to a higher rate of diagnosis at advanced stages for ovarian, endometrial, and cervical cancer. This is across the board for a variety of the healthcare specialties, and then in terms of just overall, delays from treatment, women get postponed on chemotherapy, postponed from surgery. COVID has really impacted us in a wide variety of ways, across the nation and across the world. And one of those definitely is that the healthcare field has had some delays on multiple fronts, whether it's from our side or patient side. It has, impacted us all over.
Dr. Roane, there are diagnoses that you just don't want to hear. And it seems like ovarian cancer is one of those. So if a woman is listening and facing this right now, or if a family or somebody has a friend that's facing this, what kind of advice would you give them on the hopeful side, the encouragement to keep on fighting?
Yeah, this is one of the things that I get to see every day in my practice is I've seen women come in with devastating diagnoses and hearing these terms of cancer or metastases or advanced disease, and just leaning on the people who are with them and who support them at home. And, the treatment, I'm not going to sugarcoat it, is a tough treatment to get through, but these women rise to the challenge and then they become support for other people, which is one of the things that has really surprised me. And I underestimated that the women who go through these journeys are looking to give back to people they don't even know, strangers that they just are related to or linked with through a common disease. I've seen women come to clinic with other patients just to offer support, and that's the way they've met each other. Different women will donate material or artwork to offer encouragement while you're undergoing treatment and chemotherapy. There are support groups out there. And so every day I am just blessed with the ability to help patients, but they've shown me that they are able to help themselves and help each other. And so, if those women can do it, I have faith that every other woman out there can rise to the occasion. And I think the key is just seeking out the treatment and facing the diagnosis head on so that you can get the care you need.
That was a human side of healthcare answer right there. Thank you. You know, you talked about the typical treatments that we've had for years in place, but you also mentioned there are new things that are really encouraging. What are some of the most encouraging of the new?
Yeah, one of the new technologies that's coming out is we are able to efficiently and cost-effectively analyze the DNA of your cancer. And so that doesn't just apply to ovary cancer or the other gynecologic cancers. This is all malignancies. And so with that, we're able to design personalized therapy based on specific mutations that exist within the cancer. And this has been really interesting in that we're able to design targeted therapy that seeks out the cells that carry these mutations, and we can design it so that the normal cells which do not have the mutation are not affected by the targeted therapy. And so some of these new drugs, which would include Parp Inhibitors, which is a new classification of drugs that has just been FDA approved for the most common type of ovarian cancer. These are new and exciting drugs that have been well studied in multinational trials, thousands of patients and a handful of different trials each. And they have been shown to improve outcomes in women with ovary cancer. And this is an exciting time in terms of being able to roll out new therapies that, we've been given the same 2 chemo drugs for, almost 50 years. Now we have these new forms of medication and chemo treatments that are going to add to the therapy that we already know works.
Dr. Brandon Roane, Methodist Dallas Medical Center, thank you so much for helping save some lives today. Be sure also to check our podcast, The Human Side of Healthcare, and our YouTube channel. Steve?
Thanks, Thomas, and a special thank you to our guest, especially during some of the tough times we're going through. We hope you stay safe and join us next week for The Human Side of Healthcare.